The following is an exam level guideline summary for the latest umbilical cord prolapse guidelines 2026 prevention, diagnosis and management. The guideline provides evidence-based recommendation on these key topics. Umbilical cord prolapse. Cord prolapse is defined as umbilical cord descending through the cervix beyond the presenting part, and it is an obstetrical emergency. A void prolapse is when cord prolapse passes below the presenting part into vulva vagina, and it is usually visible or palpable, whereas occult prolapse is when cord lies alongside the presenting part. It is not easily palpable or visible but may only present with fetal heart rate abnormalities. Cord presentation: when the cord lies between the presenting part and cervix before the prolapse happens. It is a risk state rather than an actual emergency. So this is the key difference between prolapse and cord presentation. So the mnemonic POC is a good tool to help you memorize these key differences. Presentation, that is, cord precedes the presenting part. Overt is when cord is outside the presenting part, and concealed is when occult prolapse happens. So the risk factors for umbilical cord prolapse are antenatal risk factors, and the key mnemonic to remember this is preterm cord. Preterm cord. P for polyhydramnios, R for rupture of membranes, E for engaged head absent, that is, the head has not still engaged. T is for transverse and unstable lie. E is for extreme prematurity. R is for repeat pregnancy or multiparity. M is for multiple pregnancy. Then C is for congenital anomaly. O is for oblique lie. R is for breech presentation or non-vertex presentation, and D is for decreased fit of presenting part. So anything which enhances the chances of an unstable lie or unengaged fetal head, also increases the risk of umbilical cord prolapse. The important points to remember include: majority remain unpredictable, most occur after membrane rupture, and risk relates to unengaged presenting part. Antenatal prevention for umbilical cord prolapse, which is recommended, is discuss admission after 37 weeks in high-risk patients. So those patients in whom we have identified the above-mentioned risk, we should offer them an admission after 37 weeks. Pre-prom with non-cephalic presentation, offer inpatient care. Individualized timing of admission should be offered. The following are not recommended. Routine ultrasound screening for cord presentation is not recommended because it has poor predictive value. Most diagnoses occur antenatally and clinically. Umbilical cord prolapse, intrapartum risk factors. Mnemonic is arm first. A is for amniotomy. R is for rotation or manipulation of fetal head. M is for monitoring insertion. Then Foley balloon induction. Then ruptured membranes with high head and station -3 or higher, and transfers or malpresentation. High-risk procedure should only occur where immediate access to cesarean delivery is available to prevent the effects of these risk factors, such as amniotomy, rotation or manipulation, monitoring insertion, Foley balloon catheter, other induction procedures, ruptured membrane, high station and transverse malpresentation. Diagnosis: suspected cord prolapse when there is a sudden fetal tachycardia, variable decelerations, abnormal CTG after rupture of membranes, a cord is visible or palpable vaginally. Always perform an urgent vaginal examination if you are suspecting such a thing. So when do we need to perform an urgent vaginal examination? Whenever we detect sudden fetal tachycardia, variable decelerations, abnormal CTG with rupture of membranes, and we detect a cord or cord is palpable vaginally. Emergency management algorithm. Step 1 is call for help, like in an emergency. Active obstetric emergency: notify senior obstetrician, midwife, anesthesiologist, neonatologist, theater, and porter. Use ISBAR recommendation. Step 2 is to relieve cord compression. There are immediate maneuvers such as manual elevation of the presenting part, knee chest position, Trendelenburg position, exaggerated Sims position with left lateral, and avoid handling of the cord unnecessarily. The step 3 is fetal assessment through auscultation and CTG if feasible. Step 4 is preparing for delivery with IV access, consent, shifting to theater, and neonatal team being on board. Step 5 is delivery. Goal is to diagnose to delivery interval to less than 30 minutes, like in cases of any of the fetal distress. Usually, emergency cesarean section is needed, but vaginal birth only if the patient is already fully dilated, there is imminent birth, which is the safest and quickest option. Step 6 is post delivery care. We should check for cord gases, document the incident on the incident form, and debrief the parents, debrief the staff. Now, the bladder filling is also one maneuver. It is useful when in community setting. There's a long transfer time and delay is expected to be more than 30 minutes, and theater is unavailable. Not routine first line management, we should keep in mind. Tocolysis can also be offered, although it is not first line, and it is considered only when persistent fetal heart rate abnormalities persist and the delivery seems to be delayed. Remember, risk of uterine atony secondary to tocolysis. Home birth. Women should be assessed initially and reassessed throughout pregnancy. Transfer immediately if prolapse occurs. Dial emergency services like 112 or 999 and inform receiving hospital. Mode of birth, cesarean section is preferred in most cases unless a vaginal birth is imminently possible, or the cervix is fully dilated with clearly faster than C-section and it is considered safe for the fetus, like there should not be any signs of obstruction. Target is to minimize the diagnosis to decision interval to less than 30 minutes. Communication using ISPA method. Maintain continuous communication with the woman, birthing partner, obstetric team, theater, neonatal team, and umbilical cord prolapse prevention, diagnosis, management. Debriefing should be offered to parents immediately after birth, and postnatal review should be conducted, and birth reflection services where available. Staff needs to be debriefed, team learning, and reflection improves the standard of care. So, regarding the incidence, umbilical cord prolapse is a rare obstetrical emergency. The commonest trigger is rupture of membranes, and biggest intrapartum risk being amniotomy with a high head. Diagnostic clues include bradycardia after rupture of membrane. Best diagnostic test is a vaginal examination. First priority is to relieve cord compression so that fetal oxygenation compromise can be minimized. Manual maneuvers include elevating the presenting part, maternal positions such as knee chest position, Trendelenburg position, and exaggerated Sims position help to minimize pressure on the cord. And bladder filling is considered if delivery interval is more than 30 minutes, so that sustained pressure is there to keep presenting part elevated and relieve pressure from the umbilical cord. Tocolysis is not the first line thing to be used, and it is associated with increased risk of PPH. Definitive treatment is immediate birth. Preferred mode is emergency cesarean, or if the patient is already fully dilated and you are expecting a cesarean delivery interval of less than 30 minutes, then it is the vaginal delivery can also be considered, even with instruments being carefully applied. Team communication is done through ISPAR tool. Post-event cord gases should be sent for pH. Documentation must be made. Parent and staff should be debriefed and documented. Prolapse means push the presenting part up. R is rapid call for help. O is operative birth, usually cesarean section. L is for left lateral or knee chest position. A is assessment of fetal heart. P is for preparing the theater. And S is speaking using SFAR. And E is expediting delivery within less than 30 minutes. This condensed summary covers the key definition, risk factors, prevention, diagnosis, and emergency algorithms, and you are expected to cover and answer the key exam concepts using this revision summary. Thank you so much.